Dr. Liegner, our Lyme literate medical doctor, is here to educate all of us, and he has traveled far to be here. So we are very, very lucky, and we have saved, well, they're all the best, but here he is.
Hello everybody, can you hear me all right? I want to thank you, Rebecca, and Lyme Western New York folks for inviting me up. And it was a long trip up here, but you know, on the way up, I had an opportunity to speak for about probably 2 hours straight with Alan McDonald. And we talked about a lot of different things. Alan McDonald is the world's #1 living pathologist about Lyme disease. And that raises an important question. Where is the next generation of pathologists for Lyme disease, and who's training them? Really nobody. But actually, Alan has a draft of a paper that hopefully will help to educate more pathologists to do the proper workup for evaluation for Lyme disease. So people have covered a lot of the things that I was going to talk about. A lot of the prior speakers have covered some of those things. So I'm going to wing it a little bit and probably modify my comments. This is a tree in Dutchess County, not far from where I live. Supposedly the oldest tree in Dutchess County, a sycamore. So as you all know, Lyme is what they call a zoonosis, just a term to describe diseases in nature that are transmissible to man. And I'm not going to go into all of the details. I think many of you are hopefully familiar with it already. This is what I call PERP1, the adult female deer tick. Some of these pictures are from Derlin Fish, who's a medical entomologist presently at Yale. And these are adult female deer ticks in the palm of the hand. I describe them about 2/3 the size of a cantaloupe seed. And this is a nymphal deer tick adjacent to a human fingernail, just to show how tiny they really are. Excuse me. And this is a partially engorged nymph. So when they're not engorged, they're even smaller. They really are about the size of a poppy seed, and very easy to miss. This is the business end of the deer tick. And I love showing these pictures because they're so cool. This is a scanning electron microscopy. And you can understand, seeing this, why it's so incredibly difficult to remove an embedded deer tick once they're well embedded. And the deer tick, when it is done feeding, what it does is secretes enzymes that basically dissolve the skin so it can just kind of plop out. And I call this a feat of animal engineering, an amazing feat of animal engineering. This is the other surface of the undersurface of the deer tick, and I just want to point out to you over here, these things are called chelicera, and they're like little teeth, and they kind of incise the skin, so the hypostome, that's the jagged thing, can be inserted, and as you probably are aware, these ticks are amazing creatures also, and they secrete many different kinds of enzymes when they're feeding, including the local anesthetic, an anticoagulant, and immune modulators, so that which enables the pathogens that they carry to take root. This is a scanning EM of a nymphal deer tick embedded in rabbit skin. And this is PERP2, Borrelia burgdorferi. This is from the Rocky Mountain lab. And I just want to point out to you also here, you see these little membranous plebs that are shed from the spirochete. Those are very, very important in the pathology of Lyme disease. I'll get back to that in a little bit. But those are not just bland membranes that are shed off, but when they break off, these plebs contain genomic DNA. So there's definitely a purpose to them. And also, those membranes are very, very immunogenic. They're more potent for nanogram than endotoxin, which is what causes septic shock with gram-negative bacteria. And I'm going to get back to this OSPE in a little bit. This is a laser confocal scanning microscopy. This is from back in the 90s that demonstrated this laser microscopy enables one to go micron by micron through tissues. And this study enabled the investigators to demonstrate that everybody talks about the Lyme organism being an extracellular bacteria, and it is true, it is an extracellular bacteria, but it also has the capability of becoming intracellular. And this particular study demonstrated within the fibroblast, which is one of the cells that make connective tissues, that Borrelia burgdorferi is not only extracellular, but also can be intracellular. And also, it's well known that intracellular infections can be much more difficult to treat and cure than extracellular infections. This is from a study probably in the early 90s in which a woman had Lyme disease. This is from Germany. And had been treated, including with intravenous antibiotics, and then sometime later she developed some inflammation of one of her flexor tendons, and there was a great research team there, and the surgeon took a biopsy of some of that inflamed synovium from the flexor tendon, and then subjected it to all kinds of studies, including PCR, culture, and electron microscopy, and it was culture positive, DNA positive, and also on electron microscopy, you can see this spirochete nestled. These bands here are collagen that makes up your connective tissue, and this demonstrates that Borrelia burgdorferi seems to gravitate towards dense connective tissues, and that's why ligaments, tendons are often affected. And when I examine a patient, I make a point of examining areas of dense connective tissue, such as the pretibial region in the front of the legs, and also the iliotibial band on the side of the thighs. Most people, if you press there, it doesn't mean it much to them, but people with Lyme, often they'll jump off the table because they're so inflamed. The other image, by the way, over here, demonstrates the spirochete invaginating into the fibroblast, again, exemplifying that it has this capability of actually entering the cells. So many of you are familiar with the classic manifestations of Lyme disease, and I'm not going to spend too much time. They're fairly obvious, and everybody's happy when these classic manifestations occur, especially after a known tick bite, and especially after what's called the known endemic area, where the ecology has been well defined, and we know that the ticks are there, and we know that the Borrelia burgdorferi is there. But there are also often these constitutional symptoms, very, very nonspecific, and very hard to distinguish from other things, such as a viral illness. And in fact, there was a paper written by Feder at UConn of the dilemma of the so-called summer flu in children in Lyme endemic areas who present with, sort of a nondescript flu, but it's unusual to have flu during the summer. And the point of that article was to have an index of suspicion that these summer flus might denote Lyme disease. And I'm fond of pointing out that it took humankind a good 500 years to have a good understanding of syphilis. We are about 40 years into Lyme disease, and people have made all kinds of assumptions about what they think they know, and it's turning out to be a lot more complicated. So most any organ or tissue in the body can be involved, and as each year goes by, more and more different kinds of manifestations of Lyme disease are being described. And there are atypical presentations where there's no known rash, no known tick attachment, sometimes occurring in regions that have not yet been fully characterized, and they're considered, non-Lyme endemic. But also, it takes a lot of resources and determination to study these areas, and many locales don't have those funds, and they don't have trained entomologists or bacteriologists to really define it. So deciding what's endemic, it also depends on how determined your exploration has been. Then patients who are seronegative or seroequivocal, or who have Western blots that are not fully diagnostic, or who present with a manifestation that maybe has not even been described in the literature yet, and that's important to realize. Newer manifestations of Lyme are being recognized. Probably 20 years ago, a woman from, she was from the Oneonta area, who developed a cerebellar syndrome and had a classic rash on her face. And so this was, she had a cerebellar syndrome where she had difficulty coordinating, her speech was scanning, and actually when I saw her, at the time that I saw her, no one had ever reported a cerebellar syndrome due to Lyme disease. So this was the first case, and I'm confronted with this young woman, very sick, and as a physician, it is kind of frightening. You know, you don't even know what you're seeing, and it turned out that since that time, there have been many reports of cerebellar syndromes in Lyme disease. So both the physician and the patient can exist in this, what I call a state of limbo, diagnostic uncertainty, and that can be very anguishing, especially for the patient, but also for the physician it can be quite difficult. And syphilis, you may know, has been called the great imitator, and Andy Packner, who's a neurologist who was involved in Lyme disease, called Lyme the new great imitator. And then as we were discussing, as some of our prior speakers were discussing, this controversy over chronic Lyme disease, that it boils down to different competing conceptualizations of the illness and whether or not the Lyme organism can persist after the application of antibiotics, how reliable are the standard tests for diagnosing Lyme at different stages, and then controversy thrives in the absence of a highly reliable direct detection test that everybody can agree upon. So the dogma is, as has been discussed by our prior speakers, Lyme is difficult to acquire, easy to diagnose, readily cured with a short course of antibiotics. If the patient has symptoms following treatment, either the initial diagnosis was wrong, or the patient now has post-treatment Lyme disease syndrome, since there is no such thing as chronic Lyme disease. I usually get laughs on this. So, au contraire, Mooseface, Lyme disease can be difficult to diagnose. The tests are not always reliable. When we treat, we cannot be assured that the infectious agent is invariably eradicated with bacteriologic cure. And some individuals relapse following recommended treatment regimens. And the agent of Lyme disease is highly complex and has many stratagems to evade destruction by antimicrobial agents and the immune response. In some cases of Lyme disease can be extraordinarily difficult both to diagnose as well as to treat. Sir William Osler was one of the great physicians of the 19th century. He was a Canadian, and he actually set up the modern system of medical education. He set up the first modern system of education at Johns Hopkins, where you had both preclinical and clinical, where you had book learning as well as bedside teaching. And he's famous for his pithy aphorisms, and I'm going to show you a couple of them. First of all, listen to your patient. He, I guess, or she, will tell you his or her diagnosis. Learn syphilis, and all of medicine is added. And you can very much say the same thing about Lyme disease. And what I like at the end there, the greater the ignorance, the greater the dogmatism, and that's where we have been with Lyme. Actually, through Derland Fish, early on, it turned out that I practiced in Armonk in Westchester County for the first 25 years of my practice, and about a quarter mile away from my office in Armonk, it just so happened that was the headquarters of the medical entomology section of New York Medical College. And that's where Derland Fish hung out, and that's how I got to know Derland. And we were friends for a while, and we used to give talks together. He would give the ecological part of the talk, and I would give the clinical part of the talk. But it was through Derland that I was introduced to folks from CDC early on. We're talking about the late 80s, early 90s. And And they knew that I was seeing patients who either did have Lyme or who might have Lyme, and they were getting quite interested in Lyme at the time. So they asked me to send them specimens from the patients that I was taking care of, and for about a 2-year period, it was all, you know, by proper consents and everything. I would send them specimens of urine, whole blood, serum, and if I happened to do a spinal tap on a patient's spinal fluid. And I really didn't know what they did with those specimens. They just kind of disappeared. And then I found out down the line that they had forwarded those specimens to Claude Garon and David Dorward and Tom Schwann at the Rocky Mountain Lab. And they were busy developing a novel test, a direct detection test method for Lyme disease. And what did they depend upon to develop this test? Well, remember those blebs that I showed you? Okay, so there may be few spirochetes, but those spirochetes continuously elaborate these blebs. So might be few spirochetes, but zillions of blebs. So, so Dave Dorward, Tom Schwann, and Claude Garon developed a test method that detected the shed blebs in bodily fluids. And the problem with this test was that it required electron microscopy, so it was very, very costly and labor intensive to do and not really practical for high throughput commercial purposes, but it was available on a research basis. And those specimens that the CDC requested of me, they ended up being forwarded to the Rocky Mountain Lab, and probably I'm one of the few clinicians, there may have been a few other clinicians, but one of the few clinicians whose patient specimens ever were tested with this Rocky Mountain Lab, what I call antigen capture assay. And Claude provided me with this graph of the results of this direct detection method in urine, and that's, so the first column over there is the RML, Rocky Mountain Lab, and these other 3 columns are 3 different kinds of antibody assays that were compared to the Rocky Mountain Lab antigen capture. Those are all antibody assays. ELISA TQ stands for Tom Kwan. He was one of the researchers out at Fort Collins, Colorado. And then a sonicated ELISA and a flagellar ELISA. And I just want to bring to your attention this column over here. This column demonstrated that the largest shakeout of the results showed that there were 37 patients who tested positive on direct detection of the antigen in urine who tested completely negative on the standard antibody tests. So, I mean, to me, that was an early inkling that our standard tests are lousy. And these are some of the finest biomedical researchers in the world. So they have a lot of credibility. And we did report this as an abstract at the 5th International Congress on Lyme Borreliosis in Arlington, Virginia in 1992. And that's me with my co-authors. And the conclusions of this was, study results using this direct antigen detection method suggest seronegative Lyme borreliosis is not rare and lends support to the hypothesis that Borrelia burgdorferi can persist in the human host despite intensive antibiotic therapy. Because these patients, first of all, there was incredible diversity in the presentations of these patients, far beyond what you would usually expect for Lyme disease. And also, many of these patients had been very, very intensively treated, and they were still shedding this antigen in their urine. One of them was a lovely young woman from southern Dutchess County, not far from where my office is right now, who had a rash historically consistent with Lyme disease. She had important bands on Lyme Western blot that were consistent with Lyme, bands of high specificity, but she never really had a fully diagnostic Lyme testing. But she went on to develop what you would otherwise call primary pulmonary hypertension. It's a very serious condition that affects the right side of the heart and results in resistance to pumping of the right side of the heart. And she ended up in the intensive care unit at Mount Sinai Hospital, where unfortunately she died. And also, unfortunately, the physicians caring for her did not seem to care or see the importance of requesting an autopsy because there might have been a lot learned about that. So this is just, and she tested positive on the antigen capture assay. So again, it's just a little window into the complexity and what's so very, very frustrating to me is to know, this is we're talking about 20, 30 years ago, they had this knowledge. And instead of supporting efforts at direct detection methodology, it seems just the opposite has occurred, where there's been concerted effort to suppress methods of direct detection. A couple of years ago, through some of the specimens that John Alcott had developed in his SLICE study, he's doing a very good longitudinal study of bulletproof Lyme cases. And he allowed some of the specimens on his patients to be studied by different researchers. And a group at the National Institutes of Standards and Technology used a method of liquid chromatography and mass spectrometry. And what they determined was that they were able to identify membrane proteins, which actually correlated exactly with the blebs, which are rich in OSPA, outer surface protein A. And John Alcott told me that that NIST method, that those findings correlated the best with the acuity of illness of his patients. So that method, which could be suitable for high throughput commercial testing, what's happening to that method? As far as I know, this is a couple of years ago, it's just sitting on a shelf. So I'd like to know why. Okay. All right, and confounding, as if Lyme disease weren't complex enough, which it is. I mean, if all we had to deal with was Lyme, that would be plenty of challenge for me. But then you have all of these other tick-borne diseases that are also very, very complex, and some of them have a lot of overlap in symptomatology with Lyme disease, so it can be quite challenging to tease apart, what the patient actually does or doesn't have. And I'm not going to list them all, but there's a whole slew of them. This is a smear showing Babesia organisms within red blood cells. This is an image of human monocytic ehrlichiosis. The name comes from the white blood cell series that this organism inhabits, and this produces a kind of a Rocky Mountain spotted fever-like illness. And then Anaplasma phagocytophilum, that is another Rocky Mountain spotted fever-like illness that infects not the monocyte but the polymorphonuclear leukocyte. It's a different white blood cell series, and it shows the organism in the center of the cell. Again, here's the Lone Star tick, and it can produce that alpha-gal allergy. Actually, I had my first patient that I've ever seen with alpha-gal allergy, but I didn't diagnose him, somebody else had diagnosed him. But for him, it was very life-changing, to not be able to eat red meat going forward. And here's that Haemaphysalis longicornis tick, the Asian longhorn tick, which, so far they have not yet identified diseases that this tick is transmitting. It may be a matter of time before they figure it out, but just that news story of a couple of weeks ago that four heifers and one bull were exsanguinated because there were so many thousands of ticks. That's pretty scary. And they're coming our way. I'm going to use a couple of illustrative cases. Now, this qualifies me as a real Lyme doctor, right? This is my patient. You couldn't ask for a more classic, beautiful erythema migrans rash. And people say that if you have the erythema migrans rash, in a way, you are lucky, because that you have a chance of being diagnosed and treated early. And I think Holly said that. There's not much that's agreed upon, but one thing everybody agrees on: early diagnosis, early application, treatment, better outcomes. So this gentleman, I forget exactly what I treated him with, but he did fine, treated, had a little bit of follow-up and was good to go. Now the next patient is a gentleman who presented to the emergency room at Westchester County Medical Center in Valhalla with severe lancinating facial pain. And I don't know if this has anything to do with the way he was dealt with, but he happened to be Hispanic. And the physicians there decided that he was just drug-seeking behavior. And they called the Westchester County Parkway Police and physically hauled him out of the ER. Okay. The next day, he developed Bell's palsy. And I didn't include the slide, but if anybody had bothered to examine him, they would have seen a fading erythema migrans rash on his leg. So he came to me the next day, and he actually needed intravenous antibiotics. He was on them for a while. He eventually did get completely well. So I'm just saying it's easy to be fooled. And also, in this case, he was sort of like profiling, unfortunately. So those are kind of two classic, fairly straightforward cases. But I'm going to spend a little time talking about a case that's not so straightforward. A woman came to me around 1989. She was actually a pediatric ICU nurse at Westchester County Medical Center, as it just so happens. And she had been sick for a couple of years and had developed a paraparesis where she kind of dragged her foot. And she was evaluated by many different physicians. She had many spinal taps, and she had what's called a chronic meningitis, where she had elevated white blood cells in her spinal fluid. And she was seen at like the very best places, and nobody really could figure out what she had. But they knew that she had a chronic meningitis. So she was referred to me by one of her friends who had been a former patient of mine. And I studied her very, very carefully for a year. And I did every test under the sun, every test that was available for Lyme disease, tests for other conditions. I had her seen in many very fine consultants, neurologists, rheumatologists. None of us really knew what she had. And I didn't know what she had either, except I knew one thing. She'd grown up in Goldens Bridge. Goldens Bridge, if you don't know it, if you ever take 684, you'll see the signs when you go north from White Plains. It's a little cottage community with some ponds, and it's very, very tick infested. This patient had no history of any known tick bite at any time, or of any rash that would be diagnostic for Lyme. And again, her tests for Lyme were negative. But she was sick, and she was actually deteriorating. So I decided, well, I couldn't make a diagnosis of Lyme disease, but I also felt I could not rule it out, and other diseases had been ruled out, so I figured, I'm just going to treat her. I'm going to give her the benefit of the doubt and treat her empirically. So I admitted her to my hospital, which is Northern Westchester Hospital in Mount Kisco, did a spinal tap, treated her with 3 weeks of intravenous cefotaxime, which is one of the best antibiotics. It's like Herceptin, even better perhaps. And then repeated her spinal tap, and her spinal tap didn't change at all, and she was no better. And I also treated her just for good measure with maybe a couple months of oral minocycline. That also didn't do much. And then at that point, I just backed off because I figured I'd given her the benefit of the doubt. I really still didn't know what her diagnosis was. And then in the interim, so after that, it was just about the time that Derlin Fish had introduced me to folks from CDC. And a year later, this patient was continuing to decline and still didn't know what she had. She contacted me again, and she begged me for another spinal tap. So you can imagine how desperate somebody has to be, right, to beg for a spinal tap. So it was December of 1991, and I did another spinal tap on her, but this time the difference was CDC had provided me with a culture media called BSK2, Barber, Stoner, Kelly 2 media. And when I tapped her, I plugged a couple of cc's of spinal fluid, into BSK media and sent it off to CDC Fort Collins. And a couple of weeks later, I got a very excited call from David Dennis at CDC, telling me that spirochetes were growing in her spinal fluid. And I keep telling the story, but, and then he asked me, which I really didn't feel offended by it, although I could have taken offense. He said, "Ken, are you growing Borrelia in your office?" And the point of that is, Dave Dennis knew that she had already been treated with antibiotics that were supposed to cure this infection. And it was so unbelievable to him that Borrelia burgdorferi could grow out of her spinal fluid that's why he asked me that question. And that's why I really wasn't offended, because think about it. It is unbelievable, right? It's unbelievable. We have these wonderful, powerful antibiotics, and they're supposed to cure bacterial infection, right? And also the other thing is she was pretty much wheelchair bound and housebound. She didn't have any pets. So it's very, very unlikely that she was infected in the interim. And by the way, just around the time that Borrelia burgdorferi grew out of her spinal fluid, she finally seroconverted and went from seronegative to seropositive. And so at that point, then I knew I had proven that she had Lyme disease. And it puts a little different spin on things. You know, the first time I treated her, it was empiric. I didn't know what she had, but I ruled out everything else, and I wanted to give her the benefit of the doubt. But now I knew that she had Lyme disease. So she was treated after that with about, I think, 10 or 12 weeks of what's called pulse, like a high dose once a week with cefotaxime. And with that regimen, she actually improved modestly, and her spinal fluid that had had a meningitis for years completely resolved, and the meningitis cleared. And then I continued treating her with a pulse regimen, which in retrospect actually was not intensive enough. But she kind of slowly kept declining, and I really didn't know what to do with her at that point. And by the way, sorry, I forgot to tell you, this is the actual spinal fluid culture report from CDC on this patient, Vicki Logan. And I can tell you her name because it's a public record, and I actually have her consent to use her name, and her next of kin gave me his consent as well. And besides, it's public record. So this is after they grew the organism. Then they later confirmed that it was B. burgdorferi by PCR method. That's Roy Campbell from out at CDC. And then we again published this case as an abstract at the same 5th International Congress of Lyme Borreliosis in Arlington, Virginia. And there's my co-authors. You'll note this includes folks from CDC. So this is at the Centers for Disease Control in Fort Collins, Colorado. And our conclusions were, culture of this CSF specimen, BSK2, yielded a strain of Borrelia burgdorferi. Culture confirmed treatment failures have been previously reported for 3 Lyme neuroborreliosis cases in Europe. The present case, apparently, is the first of this type to be reported in the United States. This made headlines at the front page of the New York Times Science Times in August of 1993. And that's a photograph of me at Vicki's bedside at Northern Westchester Hospital Center, and that's on the cover of my book, which, trust me, I had to pay dearly for the right to use that on my book cover from the New York Times. And this is a guest commentary that was published after that, and I love this quotation from Charcot, who was the father of modern neurology at the Salpêtrière in Paris. Disease is very old, and nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. Isn't that beautiful? So here I am, stuck with this patient that I don't know what to do with. I'm treating her with intravenous antibiotics, ongoing, and she's declining. So, and she has this spasticity, which made it very difficult for her to walk. So around that time, Medtronic had developed their implantable pumps, sometimes called the Medtronic pump. Maybe some of you are familiar with it. And it turns out that they had a lot of experience with that at the Mayo Clinic, and they were using it for what's called intrathecal infusion of baclofen, which is a drug that treats spasticity, where they put the drug right into the cerebrospinal fluid. So I sent her out there to be evaluated whether that would be suitable, and also to get the Mayo Clinic's opinion about how to manage her. And they did give her a test dose of baclofen, and what happened is that relieved her spasticity so much so that it made her less functioning, because she needed that spasticity in order to transfer. So they abandoned that idea. But while she was out there, she came under the care of a rheumatologist out there. And she did indeed have some markers for autoimmunity. She had an elevated ANA, which is not that uncommon in patients with Lyme. And the rheumatologist decided, well, maybe she really has lupus. So he gave her 10 days of Rocephin just for good measure, just to make sure that Borrelia was cured. And then he gave her a big slug of prednisone. And then sent her home to Westchester County. And a month or two later, her sister-in-law called me in a panic because she was like a mess. And so I admitted her to Northern Westchester Hospital, and indeed she was a mess. She could not roll over in bed, could not hold a cup, could not remember conversations that were held 3 minutes earlier. And also she couldn't protect her airway. She was aspirating when she ate. And we did a CAT scan of her chest, and this is her chest. And if you're not medical, you probably won't realize this, but this is her ribs, okay? And this is her mediastinum, which includes the pericardium, and within it, the heart. And you don't realize this, but this mediastinum is about the size of a small soccer ball, and most of that is fluid. She had what's called a pericardial effusion, and also not just pericardial, but down here, these are pleural effusions. And if the pericardial effusion gets big enough, it can interfere with the pumping action of the heart. And you can get something called cardiac tamponade, which can be fatal. So both for diagnostic purposes and therapeutic purposes, I had one of my colleagues, Paul Cathcart, thoracic surgeon, perform what's called a pericardial window, where they take a small, like silver dollar size piece of pericardium out to allow the fluid to drain. And also at that time, I mean, it really looked like she was going to die. So I said, I won't tell you what I said, but I'm just going to treat her. So I put her back on cefotaxime, but not in a pulse regimen, daily cefotaxime for 3 months straight. And she got dramatically better. Her mentation cleared, she gained her strength, the pleuropericardial effusions resolved. She was able to walk 500 feet with a rolling walker. And just about that time, I got called on the carpet by my chief of medicine, who happened to be an infectious diseases physician. And it looked like he was getting ready to sanction me. Because here I had a patient in his hospital. He's infectious disease. He's the chief of medicine for 3 solid months on IV cefotaxime. That breaks all the rules, right? Lucky for me, just about a few days before, Paul DeRay, who was another wonderful pathologist who's since passed away, he was at the NIH, and I sent Vicky's pericardium down to him, and I'm going to skip up here. And he did what's called a touch point, where you just touch the pericardium to a glass slide, and there was this, like, you couldn't ask for a more beautiful Borrelia spirochete. Well, anyway, I just had happened to get that information a day or two before I was called on the carpet by my chief of medicine. And this is the hematoxylin eosin of the pericardium, showing an infiltrate of inflammatory cells, including plasma cells. So I said to him, did you know that she had spirochetes in the pericardium? And he said, oh, this is a complicated case. And he backed off. And that saved my butt, because he was getting ready to sanction me, I know. Anyway, so this is her a repeat CT after she'd been treated with complete resolution of the pleuropericardial effusions, and then her case was reported in the Journal of Spirochetal and Tick-borne Diseases with several other patients, and it's a very long story, and I don't have time to go into everything that happened with her and to her, but eventually she passed away, but it really wasn't from the Lyme disease that she passed away. She passed away due to, in my opinion, medical malfeasance, and she really didn't have to die when she did. But the reason I'm mentioning it to you, her tissues have been subjected to further study, and just 2 days ago, her case was reported in great detail by my colleague Eva Shapi and other colleagues, Jim Goldman, who's a neuropathologist at Columbia Presbyterian, and Jenny Levine, who's the chief of pathology at Downstate, and it's just published in great detail and proved this. And she got way more treatment. She got a ton of IV treatment, and every time she got treated intensively, she would get better. And when you stop treating, she would decline. And then around 1998 or so, there were changes in policy at Empire Blue Cross Blue Shield, which basically made it virtually impossible for her to be treated. So there was a long period of time that she didn't get treated and she deteriorated. Finally, we got some donated drug from Roche, and we treated a little bit. That wasn't enough, and then she finally ended up on Medicaid, where I thought she'd be able to get treatment covered. It's a long story. It's all detailed in the article and also in my book. Anyway, the long and the short of it is the tissues demonstrated that she had large amounts of residual Borrelia in her tissues, in many tissues, and that's the other things. When she passed away, and we were able to study her tissues, not just her brain, but her heart, her liver, and her kidney, and there are Borrelia in all tissues, and furthermore, these are in the form of a biofilm. Biofilm is a well-known entity, but it hasn't been shown that much in patients with Lyme disease. But because Eva Shapi used the special methods that she has, it demonstrated that her tissues are loaded with biofilm. Every cut of every tissue, it's not even like you had to search that hard to find biofilm. And these are large masses of biofilm. The other thing that's important about biofilm is that when bacteria reside within biofilm, they're at least 1,000-fold resistant to the action of antibiotics. So this helps to understand how it could be like a yo-yo. You treat her, and she got better. You stop treating, and the infection, rebounds. So this is the first time that I've mentioned this because the article was just published like 2 days ago, and it should be open access. I would encourage anyone who's interested to. If you just put in Shapi, S-A-P-I, in PubMed, and click on it, it'll come right up because it was the latest thing that she published. Okay. So there is a lot of things that are positive that are going on at this time, and as previously stated, a lot of the things that are positive are because of, guess what? Private funding. Because, at least up until now, if you wait for the federal government to do the right thing and fund properly, you can wait till hell freezes over, right? And the other thing is to compare and contrast the funding for Lyme versus the funding for AIDS, HIV. So the funding for Lyme has been about $25 million a year. And a lot of that funding goes to the people who says there's no such a thing as chronic Lyme disease. Compare and contrast AIDS, HIV, 2 to 3 billion a year, every year for the past 30 years. So of course, a lot of progress has been made. So I would say, don't ask for 100 million, ask for $1 billion every year from the federal government. I mean, it should be of that magnitude, in my opinion. Okay. So HHS tick-borne disease working group, first of all, I want to commend the people who worked on that. Jill, Holly, and many other people spent a tremendous amount of effort and very time-consuming, and it looks like that work is coming to some fruition, right? Some positive things. And of course, now what we need is the funding to carry out the things that are envisioned, and that's where your legislators are very important, to lobby your legislators, and that should be nationwide. I mean, this should be at least $1 billion a year, at least. Okay, sorry. And there are some great research groups, Kim Lewis at Northeastern, Ying Yang at Hopkins. I want to mention and emphasize Dr. Raja Das at Stanford and his co-workers, because he hasn't gotten the recognition that he deserves, because he's doing great work, and of course Dr. Shapi at the University of New Haven. And John Alcott is longitudinally studying patients with bulletproof erythema migrans over time, and he's doing great work as well, really learning a lot from him. And Brian Fallon at Columbia, they have their tick-borne diseases research group. They're actively working on improved methods of diagnostics, but also they have an autopsy study, and they're going to be also studying the tissues of patients who have passed away from Lyme disease. And we're on the cusp of improved diagnostics, next generation sequencing, recombinant antigens, microarrays. Series Nanoscience has their Lyme nanotrap, which I think, as far as I know, we still can't use it in New York State physicians. But it's a very promising technology, and I just heard him talk at the Columbia LDA conference in Philadelphia, and he's doing great things with that. And I think it's not just for Lyme, but for many other infectious diseases, again, where it's picking up complex antigens in the urine. And then again, NIST's membrane method, which is again, disappointingly sitting on the shelf, and I don't know why that is not being exploited. And I think there will be other direct detection methods to come. And then in terms of efforts at prevention, Rick Ostfeld and Felicia Keesing at the Carey Institute they're in the fourth of a 5-year study of neighborhoods in Dutchess County, in which they have 4 different groups. One where there's placebo, one where they're using bait boxes, one where they're spreading entomopathogenic fungi, that's a fungus that will destroy ticks because it destroys the chitin, and one in which both the bait boxes and the entomopathogenic fungus is being used. And this is not just in terms of controlling ticks, but to determine does it have an impact on the incidence of Lyme disease. So he's a great scientist, and hopefully we will learn something of benefit to us from that work. Kevin Estveld is, I don't know what they're going forward with this methodology to using CRISPR technology to make field mice or white-footed mice inhospitable to Borrelia burgdorferi. It's a way of sort of immunizing the mice against Borrelia burgdorferi as a way of diminishing the risk of Lyme disease. Jill, do you know if that's going forward or not?
So far it is, but there's also work that's been done by another researcher using gene editing, and it's also very exciting.
Okay, so Jill's saying there's other researchers are doing gene editing techniques on ticks. So yeah, and then there is a new Lyme vaccine that is being kind of rushed through by Valneva. I don't know what to think about that, but and then there's the 4-poster for area-wide control of ticks, which actually has been shown to be rather effective, and I think didn't tell me they're adapting that so it doesn't require corn. It's going to use a salt lick or something. Well, there's no point my patent's lapsed on my dear gazebo. Sorry. Okay, now this is Kim Lewis. About 2 years ago, in the fall of 16, one of my patients brought to my attention, which I didn't even know about at the time, that there had been a conference sponsored by the Stephen and Alexandra Cohen Foundation through Mount Sinai School of Medicine. What they called it was Lyme disease in the era of precision medicine. So now, that's right in New York City. I'm in Dutchess County, but I didn't even know about that conference for some reason. But one of my patients had been following the work of Kim Lewis probably about as long as I had known about Kim Lewis's work. And he must have gotten wind of this conference, and it turns out that at this conference, Kim Lewis was the keynote speaker. But more than that, they video recorded everything that went on in the conference, and then he put it out on YouTube. So my patient discovered this keynote speech by Kim Lewis on YouTube. And towards the tail end of his keynote speech, he makes this comment. And he gives credit to Dr. Rajadas at Stanford, who, with one of his younger investigators, had determined that in the test tube, the most active agent against Lyme disease, bar none, was this drug called disulfiram. Do you guys know what disulfiram is? Antabuse. So disulfiram is a drug that's been around for 60, 70 years. And it turns out that if someone's having a problem with alcohol and they want to try to stop, antabuse is often prescribed. And the reason is that if you drink while you're on antabuse, you get really, really, really sick. It's like the worst hangover you've ever had in your life. So it's aversive conditioning to try to help people with it. Stay on the wagon, right? Stay on the wagon, the right term. So anyway, so my patient tells me about this at one of his visits, and because of that, I looked at the video, and then I went to the actual paper. I went to the actual paper that it's based upon. I read it, and then the next time the patient's in, he says to me, "Hey doc, can I try this stuff?" So I thought about it. You know how much experience I had with disulfiram at that point? Zero. Because it's not my field. But I knew that it existed, so I did a little bit of research, found out a little bit about the drug, what its side effects were, and it seemed like it's a fairly safe drug. And this patient was a very trustworthy patient, very compliant, and I decided to let him try it. And I said, here's the deal. I want you to stop your other medications, and anytime that he'd stop, just like Vicki Logan, he would deteriorate. And he had Lyme and babesiosis, it turns out. He was on industrial strength doses of amoxicillin, high dose of minocycline, and high dose of malodorone. And on that, he was able to be kept pretty well. He was able to have a life, go about his business, but nobody really wants to be on these drugs, right? Unless they have to. So anyway, I just want to show these pictures. So this is Ravi Pothaneni. He was the first author on that disulfiram paper. And this is Jayakumar Rajadas. He's the chief investigator at Stanford. Again, he needs more recognition and funding too. And this is disulfiram. That's the molecule, disulfiram. So anyway, so I agreed to let him try it, and I gave him a prescription, and I said, I want you to have surveillance labs every couple of weeks, and he was very compliant. He did that. I said, I want you to send me a note every couple of weeks, let me know how you're doing, because he lived way on the East End, Long Island. It was not that easy for him to get up to see me. He was compliant with that. And then a couple of weeks later, he leaves a message on my office voicemail, canceling his follow-up appointment and declaring, I'm cured. And then he mentioned in passing that he had required a hospitalization, but he didn't tell me why. So naturally, I'm keenly interested, right? So I call him back up, and he tells me that he's fine, he's doing well. And I said, what did you need to be hospitalized for? And it turns out that he had required a psychiatric hospitalization, which he had never required before. So I did a little bit more research on disulfiram. It turns out disulfiram can affect neurotransmitters, and there have been some occasional reports of emotional disturbance, even psychosis, with disulfiram. So I called him back up, and I told him about that. And he says to me, yeah, doc, I don't really think it was the disulfiram, because he was in the middle of a very stressful, situational stress. He was in the middle of a nasty divorce. And then he says to me, but even if it was worth it. And don't fail to offer that to other people just because of that. You can almost see him pointing his finger at me and admonishing me over the telephone. So, first of all, I've been in this field 30 plus years. I've never seen anything like this. So it really got my attention. Meanwhile, 27 months out, he's well. On nothing. So after that experience, those of us who take care of the disease that doesn't exist, chronic Lyme disease, we kind of collect these difficult cases, right? So I shared this information about what I call case one with a couple of other patients of mine, one of whom, and then, well, anyway, I ended up reporting the first 3 cases, and that finally was published May 30th. And if you want to know the details, they're reported in great detail. But the second patient was a retired physician who had bulletproof central nervous system Lyme. You could not ask for better documentation of central nervous system Lyme. And again, this is a case like Vicki Logan. You could not stop treating him, and orals were not adequate. So he was on a long course of IV, then he got Lyme infection and sepsis, could have died from that. And then he couldn't be maintained without Rocephin, so he was on intramuscular Rocephin for a year or 2 or 3. And so I mentioned this case 1 to him, and this is a physician, and he thought about it, he discussed it with his physicians, I discussed it with his physicians, and we all decided, you know, it's worth a try. So that was the second case. And it's a long story, but he was only treated for 6 weeks, and everything that happened to him is detailed in the article. And you know, I call him up, and he says to me, I think your treatment worked. He was more than a year out, doing fabulous, able to be off all of his antibiotics. His psychiatrist, he had a lot of neuropsychiatric issues. His psychiatrist was able to wean him off of most all of his drugs, doing fabulous until he had another tick attachment. And then the mid-level in his doctor's practice wouldn't treat him, and then he started getting sick. So he just got another course of disulfiram, which actually his psychiatrist prescribed. That's the crazy thing about disulfiram. Disulfiram is within the scope of practice of psychiatrists. So whereas psychiatrists might not feel comfortable prescribing antibiotics, they are comfortable prescribing disulfiram. So that was case 2. Then I had case 3, who was a patient of mine for 25 years, very well documented, police officer, same kind of situation. I could not stop treating because he would deteriorate. Anyway, and it's a long story, and he did overall very well as well. And that's what prompted me to write this article. And then I am giving a couple of talks just on disulfiram in the near future. So Dawn, my office nurse, now I have this confession to make. I'm not a techie, and I don't know Excel. So this is a summary of the first 30 patients that we treated and completed treatment. And it's a lot of data there, but what the summary points are, I would say about 85% of them reported feeling significant net benefit from receiving that treatment. There's a column that shows some E's over there, and that E, those E relate to those patients in which we're able to say they enjoyed, quote, enduring remission, meaning they've been well for more than 6 months on no treatment. A lot of these other patients, I haven't followed them long enough to be able to say that. But also, there are some problems that can occur. A significant number of the patients had neuropathy, which often occasioned us to decide to stop treating them at that point. Some of them had a couple of neuropsychiatric upsets, not psychosis, but again, clearly related to the disulfiram. So it's a drug that does require care, and I think any physician who's using it really should inform themselves carefully. And the other thing is, I think it's important to, and its uses are being defined, and what's the optimal therapy is being defined. What's the minimal dose that's necessary that you can maximize the benefit and minimize the risk. It is a drug that can have significant neurotoxicity, so it's not to be used lightly. But on the other hand, I have never considered it, or I'm not saying that it's a cure. I don't know that it's a cure at all, but it's another tool that we didn't previously have in our toolkit. And it's not an antibiotic in the usual sense. And I don't even recommend that patients use probiotics when they're on disulfiram. And the other thing that was completely unexpected, those first 3 patients all of them happened to have babesiosis as well as Lyme. And their babesiosis apparently has become a non-issue as well. So if you can think about a drug, you guys know what borscht is around here? Borscht? It's cheap as borscht. It's cheap as borscht. And if you can knock out or knock down Lyme and babesiosis with a single agent that's used for a finite period of time. That's big. So I'm not saying it's not without its problems, and I think it has to be used with care. But this demonstrates the importance of acknowledging a problem, the importance of private funding, because none of this would have happened without private funding. And it also indicates what happens when bench researchers, frontline clinicians, and patients advocating for themselves come together. And I also want to say, I would never have suggested this to this patient. It's only because the patient requested it of me that I agreed to let him try. And I also think there's going to be other agents, different agents, maybe better agents coming down the pike. I know that Dr. Rajadas is very excited with aslocillin, which is a penicillin, very similar to amoxicillin, very, very, very potent. And right now it's available only in IV form, and for some reason it's not available in the States, but Dr. Rajadas has in mind to make that into an orally absorbable formulation. And so to have a drug that has as little toxicity as amox and way more potent is very exciting. So I think, we've heard a lot of bummed out stuff here, but I think there's reason for hope, and I think all of us have to do our part, and especially the patients, through the legislators. We need $1 billion a year. You want to see progress in Lyme and tick-borne diseases? You'll see it. $1 billion a year. Thank you so much for your attention.
Thank you, everybody that